Hiya, hi guys. Thanks for anyone who's just hopped over from the titty gritty. You weren't first though, to be fair, Michelle. How is everyone? What a way to spend a Tuesday evening. Hi Chris. Talking menopause. I don't think that actually you can talk about it enough, to be honest. Right, let me just go live with Dr. That name. Hi there. Hi, Joe. Hello.
Hi, Helen.
Oh, so nice to see you.
Yeah, nice to see you too.
So last time I saw you, we were in a sort of a drizzly Devon.
We were enjoying
Devon or drizzly Cornwall.
Where were I think it? Oh, Cornwall.
Cornwall.
It was Cornwall. It was drizzly. It was cold. It was everyone's summer holiday this year, wasn't it?
It absolutely was. It's so nice to see you, and I'm so happy that we are talking about. I feel like I'm talking about menopause a lot at the moment, and I think it can only be a good thing that it's not that she's going through the menopause sort of thing. It's good. I feel like we're taking ownership of it a little bit.
I think it's really good that it's being talked about in general, but what that's meant is that a group of women who are experiencing essentially what is menopause is estrogen deficiency, and you can experience that for all sorts of reasons, particularly as because of cancer treatments. So I think that's really good that those women who might have been left out of this conversation are now hopefully not being.
Absolutely. So you specialise, so as well as being a GP for umpteen years, you sort of specialise in menopause, don't you?
Yeah. So that's what I do. So I work in the NHS in a menopause clinic, and I work in a private clinic as well. But obviously, having been a GP for over 20 years, I've worked with a lot of patients who've had breast cancer as well. Although I think or any types of cancers, but I think that's where the difficulty lies, is that a lot of the management of patients who have cancer is not in the hands of GPs. It's with the specialists, and then perhaps those dots don't get joined up when women are then struggling with symptoms because of their treatments.
Yeah, and I think that that's definitely anecdotally what I've heard from a lot of people within the certainly the breast cancer community, where you're told all about chemo and radiotherapy and then you're told very little about the after effects of sort of the mental side of coping with it, but then also the hormonal changes that you go through. And I have to say, being forced into the menopause like I didn't recognise myself overnight. I was like, oh my God, it was almost, dare I say, worse than going through some of the chemo parts of it, because at least with the chemo, I knew there was an end to it. Whereas it's that feeling of, well, this is it now. My life's over. Like, you sort of mourn what you had before a little bit.
And I think what's really important about that, and you and I have talked about that before, is that rightly so, you are really counselled and prepared for how chemotherapy might make you feel, how radiotherapy might make you feel, and you have a lot of support with that, and you're warned that you might get some symptoms with treatments that you're taking, but perhaps not in enough detail. Perhaps we're not, my finding is that we're not giving enough sort of emphasis to supporting women in understanding what that might feel like.
And I know behind the scenes you're working on changing that, which is very exciting, and it'd be good to talk more on that at some point. But can we start with, so why is it that we're pushed, some people that have been on cancer treatment, and I think it's particularly breast and perhaps ovarian, some of the gynae cancers, why do we get menopausal symptoms? Why do we go into menopause?
I think it's important. It can affect women with all sorts of cancers, and we do focus a lot on breast cancer because a large proportion of breast cancers will be estrogen receptor positive. which is really good in some ways because there are really effective treatments which can then block or reduce the amounts of estrogen that your body's producing. But anyone that has any treatment that either knocks your ovaries off in terms of how much estrogen they can produce, or you've had your ovaries removed, or any of the treatments which then reduce those levels. So anyone that's had certain types of chemotherapy, anyone who's had any body irradiation that's involved their ovaries, can essentially end up with menopausal symptoms, because menopause is estrogen deficiency. So that's why anyone can end up with that. And there is a particular focus then on breast cancer patients, which then equally, I think breast cancer patients feel left out of the menopause conversation, but then other patients who've had other cancers probably feel left out of it as well, because often, you know, younger women who've had treatments for things like leukemia, not across the board, but may have ovaries that don't regain their function.
Right, okay. So what are the common symptoms that I know what symptoms I went through, but what are the common symptoms that you find people that have been through cancer treatment that are showing menopausal symptoms? What are the common ones that they're coming to you?
So I think
and they have a problem?
Any symptom that you can get with what we would expect in a natural menopause, you can get in an artificially induced menopause for whatever reason that's happened. But I would say, obviously, hot flushes and night sweats that everyone knows about, mood changes, so feeling that your mood's all over the place, that you're particularly tearful, that perhaps you're more anxious or more easily overwhelmed than you used to be. Dry, itchy skin, and vaginal symptoms, which I think are, so vaginal dryness, soreness, bladder symptoms, your bladder feeling irritable, so you need to go more often, or you need to go urgently. And those side of symptoms are talked about very little, and obviously that has a big impact on not only how people feel, but their relationships as well.
Yeah, absolutely. And achy joints as well, somebody.
Oh yeah, absolutely. Achy joints, and that can be particularly bad with the aromatase inhibitors that some women will take for their breast cancer treatments. That tends to be, the symptoms tend to be worse with aromatase inhibitors, because it's effectively mopping up every last little bit of estrogen that your body can try and convert from testosterone. But you can get it with tamoxifen as well.
Yeah. And the other one that I find that frustrates me daily is my ability to retain information. I used to be so much sharper than I am. But the amount of reminders I've had on my phone today just to say that I'm speaking to you today is laughable, because I know that I just forget, and I find myself in these really embarrassing situations where I'm somewhere where I'm not supposed to be, or I'm late, or I'm early, or you know, and I cannot bear it. But it's
and I think that just feeling like your brain is a bit cotton woolly, that it's not functioning at the same speed that it used to, and that will really vary depending on what treatments women are having, or whether they've actually had their ovaries removed, because we've got to remember estrogen plays a big part in this, but testosterone can play a part as well. And if the ovary has been removed, or its function has been sort of quietened and down regulated, which it is for some women as well, or it's been knocked off by radiotherapy or whatever, testosterone is going to be affected as well. So we can produce it from other areas in our body, but the ovaries do produce a significant amount.
And a question that I get asked a lot is, how long will these symptoms go on for? So if you take, so I was 39 when I had my diagnosis, so I wasn't quite menopausal. So I am on tamoxifen. Will my symptoms last like for the next 10 years whilst I'm on tamoxifen, and then I come out of it and then I'll go into a natural menopause? Or is it really hard to,
it's really hard to say, and everybody's so individual. Lots of women will find that their symptoms are worse when they first start on treatments, particularly women who are premenopausal, who haven't even started to lose any of their estrogen yet. That sudden lack of response to it, lack of amount of estrogen going around, or blockage to estrogen, particularly women who've had their ovaries removed or switched off, that really sudden drop can be really, really significant and hit women very hard. Some women find that their symptoms, their sort of tolerance of medication improves a little bit with time. I don't know if you found that at all.
I've got to say, I've definitely found that it has improved, for sure. My hot flushes are really few and far between now. My cognitive thing is not great. But no, I generally feel like I've almost, my body's got into a rhythm with it, which is amazing.
And it is amazing, and it's amazing that the body can do that and can adjust. So some women find that, some women don't find that happens. And where you would be when you stop your tamoxifen, it's really difficult to say, because we don't know where your own body is at this point. So for premenopausal women, it's difficult to say where you will be when you stop your tamoxifen. But whilst you're using a treatment, you are likely to continue to having symptoms for to some degree.
Oh, I lost you then.
Sorry, I never know how to turn all the notifications off.
I know. Oh, it's so hard. Somebody's just saying that their mood's actually worse 5 years into Zoladex. Zoladex is a bugger. I don't know if you know too much about that. I've got lots of friends on it, and they really struggle. Some of it's really
well,
tough.
Zoladex is used in premenopausal, normally premenopausal women, largely to quieten, to shut the ovaries off, to quieten that down. It essentially just shuts it off. So there is no estrogen production from the ovaries at all. And then, oh, sorry, I don't know why it keeps going off.
That's all right.
Sorry. So there's no production, so there is no estrogen there. And then they might be on other treatments, which are then reducing any estrogen that you could be producing anywhere else in the body further. So I think in terms of symptoms getting worse with Zoladex, some symptoms might get worse with time. So if vaginal dryness and soreness symptoms are not helped or managed, that can get worse with time. I suppose things like mood symptoms might just be that actually you've been putting up with it for such a long time, and struggling, that actually it feels like it's getting worse. Rosie's just put, oh no, please don't say that. I think that might be about vaginal symptoms. There are treatments, and that won't get worse for every woman. It's just that is a symptom which for lots of people their body doesn't get that much more used to.
Yeah, and I would say about that, Rosie, is like the other drugs, Zoladex, if you've just recently got onto it, hopefully you'll get into a rhythm, as well with it.
And I think it's really important to acknowledge as well that whilst we're talking about how it can affect people, not everyone is the same. We're all so individual. And some women might not, the same as a natural menopause to some degree, some women might not notice very much at all and might have a few nights, so let's not feel that bad with it. So I think it's really important to not be too doom and gloom about it, but that women understand what symptoms they could have, and can have some support with that, and can talk about it with people, because like you said, you've probably had lots of support through the other types of treatment, and actually what you need is people to say, we understand this bit can be hard as well.
Absolutely. Self Trends is asking, any reasons why some people go on Zoladex and aromatase inhibitors and others on tamoxifen?
It really, I'm not an oncologist, so it's really specialised, and that would all be to do with what particular grade of cancer someone's got, what that would be worked out as a real individual. So
and your age, and it's difficult to answer that one, isn't it? Somebody's just asked about they've had their ovaries removed. They'd had breast cancer, and I think preventative, had ovaries removed. Does that affect hair growth?
In
or
terms
hair
of,
loss?
I mean, some people find that estrogen, a low level of estrogen, can sort of shrink the hair follicles, and that can mean that you don't have as much hair growth. Another thing that can happen is whenever we go through a big hormonal change in life, our hair can go into a cycle of shedding. So anyone who's had a baby will probably remember when you lose loads of hair. And it can happen due to all sorts of reasons. So hormonal change, stress, the fact that you've got low estrogen, sometimes testosterone can play a part in that, but there's lots of reasons why you could have hair loss at that time.
Yeah. And Anne is asking, why do our bodies feel achy, especially after inactivity?
Feeling achy with low estrogen is really common. You've got estrogen receptors all over our body, so some people really notice when the levels drop that their joints aren't as lubricated, they don't move as much, and actually it's the same as lots of things. If you've got to move it and keep those joints supple and moving, so actually that's why it might feel more achy after you've not been doing anything.
Yeah, it's interesting, isn't it? Because I find as well with I get quite bad fatigue sometimes, and actually by doing exercise I feel like that sometimes re-energizes me as much as having a cat nap would have done. So
absolutely.
Sometimes you always have to do what your body doesn't think you need to do.
And I think exercise is really good for obviously releasing endorphins, helping that weird thing of, like you've said, feeling really fatigued and then doing some exercise and having more energy. And there's a lot of evidence that exercise really helps with estrogen deficiency and menopausal symptoms anyway, so there's probably the knock-on effect of that as well.
There was a question just a second ago about somebody takes paracetamol for their aches and pains. Is there anything else that you can take other than paracetamol to help with achy joints?
So exercise is good. Things that you can actually do. Exercise is good. Things like yoga. There isn't anything specifically which is going to help with achy joints in terms of sort of non-hormonal medications that we can give to help with menopausal symptoms. There isn't really anything which sort of encompasses that achy joint side of things. I think, occasional paracetamol would be okay. You wouldn't really want to be taking something all of the time.
Now, one of the big questions was, what are the treatment options for these menopausal symptoms? I think this is the crux of what everybody wants to know is, you know, they're nervous about the whole HRT thing. What can we do to try and alleviate this?
So I think the biggest part of all of this is that it needs to be individualized to that particular woman, to what her symptoms are, because what might be really significant for one person might not be bothering someone else at all. I know people are probably sick of hearing it, but lifestyle underpins everything. So things that really help with menopausal symptoms are reducing stress, which is often difficult at that time. Things like yoga, exercise, eating well, trying to really prioritize sleep. All of those things are really going to help. But then there are non-hormonal medications as well as hormonal medications that we can use for women who HRT wouldn't really be the first choice. Now obviously we can't make a sweeping statement about all cancers and whether people would be able to have HRT or not, because there's lots of women who would be able to take HRT, but in estrogen receptor positive breast cancers it would never be a first choice. And that's essentially because the treatments for breast cancer are really good, and fortunately that's having a real impact on survival. But those treatments do focus on reducing estrogen in the body. Now that's not to say that no one ever goes on to have HRT prescribed for them, but there are lots of things that we ought to be trying first and think. So there are different groups of drugs that might help for different people. So there are groups of antidepressants called SSRIs, which are particularly helpful for hot flushes and night sweats, and there are some that are better than others. And I know that the thought of taking an antidepressant can be really off-putting for some people, but particularly
I wish they wouldn't call them antidepressants. I think that's part of the problem, because it comes with a stigma, doesn't it?
And I think that's really difficult, because it really shouldn't come with a stigma, because depression should be treated as much as any, but I think when you're not taking it for depression,
Yes.
that can feel like that, really,
Yeah.
because you're like, well, hang on a minute, this isn't what I'm doing. So yeah, if they're called SSRIs, if we call them that, then they can help. They can help with mood, they can help with sleep, they can help with anxiety, and they do help with hot flushes and night sweats. Like I said, some are better than others, and some of them you can't take if you're taking some medications like tamoxifen. There are certain ones that you can, so it's important to get that right. And then there are also other medicines which are being looked at a bit more at the moment. So there's something called oxybutynin, which traditionally is a medication for sort of an overactive, irritable bladder, but that's been found in low doses to really help with hot flushes and night sweats as well. But also, if someone was having irritable bladder symptoms, that'd be a good one to go for, because it would sort of kill two birds with one stone. Traditionally, there was some some blood pressure medications that have been used, something called clonidine. There's not a lot of evidence supporting that being great, but I have had some women who've done really well with that. And although a lot of the treatments focus on sort of hot flushes and night sweats, there are some new drugs being developed at the moment which work directly on the centre of the brain that controls our temperature. So hopefully within the next couple of years they'll be available as well for women who that's their is a big part of their symptoms.
These SSRIs, these antidepressants that you can take, do you get dependent on them? So that's the other thing I worry about, is having something that then can you get too reliant on them?
That group of antidepressants people don't get dependent on, and you only need to use very low doses for controlling. For if depression and anxiety is part of what someone's got, then you would treat it as you would anyone who'd got that going on. But for menopausal symptoms, it only often needs lower doses. So that means you often bypass the side effects that some people might get, because they can come with some side effects like anything. And no, that group of antidepressants don't come with a dependency. If you were stopping them, you might want to wean it down slowly so that your body gets a chance to adjust to coming off it. But it doesn't mean that you're going to need higher and higher doses and you're never going to be able to come off it.
Okay, that's interesting. So I wondered whether it was something that could sort of escalate out of control a little bit. Somebody just asked a good question, which I suffer from as well, saying headaches, menopause, relating to the menopause. Is there anything that can be done about that?
So there's lots of medication that can be used for migraines. So there are migraine specific, which would be the same whether your migraine is due to your hormones or not due to your hormones. So there are medicines which work at the time when you've got the migraine, and if you're not having migraines really frequently, then that would be an option. Or there are medications which can actually work to try and prevent people from getting migraines, which would be non-hormonal. So that would be an option as well.
Would that be a case of going to your GP and talking
specifically about your migraine and the treatments that you could have for that? And I think it's important to think about some complementary therapies as well, because there's quite a lot of evidence for acupuncture with migraines. So some women might do really well with that. And actually, I mean, I work in Sheffield largely, and I know it's possible when you've had cancer, there's a centre called the Cavendish Centre where people can access those sorts of therapies and have acupuncture and that type of thing. And I would like to think that's there are that facility nationally.
I actually had acupuncture as well. I was referred to it by my oncologist, and I had 6 sessions to help with my because my hot flushes were just out of control. And it was phenomenal how effective it was for me. So I really, I always say to people, give it a go, because I found it so helpful.
Absolutely. And I think in those situations, a lot of the time, the reason that those treatments don't have a big evidence base behind them is just because the studies haven't been done. And I think acupuncture has, you know, has a lot of evidence, has some evidence behind it. Hypnotherapy has some, definitely CBT, yoga, all of those things have been proven to help. So I think it's really important that the net's cast really wide when we're trying to help people, so that we think about what sort of plan, what toolkit can we put together for you to help you navigate through this. And for some women that might just be having their symptoms acknowledged, and I don't mean that in a dismissive or a patronizing way, but sometimes just talking about it and saying, look, this feels really rubbish, and someone saying, I know it does. It actually can be really helpful in trying to work through that, and even knowing that there are options.
Absolutely. Honestly, it does make such a difference. Sarah's asking, is there a link between estrogen deficiency and Alzheimer's?
So there's quite a lot of evidence into quite a lot of research at the moment into the way that estrogen affects the brain. There's a neuroscientist in the States who's been doing quite a lot of work called Lisa Mosconi, and low estrogen does look as though it affects the way that the brain functions, but her research has been showing that it also looks as though the brain, a bit like puberty, that the brain learns to cope with that change, and learns to adapt to having lower levels of estrogen. So although that sort of brain fog and lack of concentration, and that it looks as though you might then adapt to that further down the line, that doesn't make it any easier when you're experiencing it. I think the link between estrogen and dementia is not it's not a definite link at the moment.
Right. Oh, interesting. Okay. Yeah. I'll keep my eye on that. I'm quite interested in the whole dementia. It's something I do worry about, dementia.
Yeah, no, absolutely. And I think what is really difficult in that situation is, potentially estrogen does affect the way that the brain functions, but if you are in a situation where you're trying or needing to avoid estrogen, or your estrogen needs to be low, it's really difficult when there's then negatives like that to focus on as well. And I think it's important that we look at the things that estrogen can have an impact on, and really we need to focus on, like bone density. And that's really important to think, right, actually what in things that we can do something about and prevent happening. I think it's really important that we focus on those and help women, look at ways. But it's difficult when there's something that potentially we wouldn't be able to do anything about it in any case.
Heather's just asked me whether I stopped after the 6 acupuncture thing, and actually I stopped after 6, but if they were to come back I would definitely do more. But it really did, she described it to me like it was like my body was like a thermostat and it needed like readjusting, and she readjusted it, and it's so far so good. Now another question that I got was weight gain. Is this something that you hear about a lot?
So weight gain during the menopause is a bit complex. It's probably due to lots of different factors. One of those is simply that where you hold your weight can change. So as estrogen drops, we tend to carry weight in a bit more of the same way that men do. So around your tummy, around your middle. So it can feel obviously that your clothes have got much tighter, you don't feel like yourself. And that's because your body is trying to make a little bit of estrogen from the fat cells, which I won't go into detail about that, so I don't want that to frighten people, because some of the treatments that people would be on would be specifically targeting that anyway, your body being able to make estrogen from other sources. So that's one way. Another way is that you can lose a little bit of muscle mass, and our muscles keep our metabolic rate a little bit higher because they burn energy and calories all the time. So actually, if you're losing a little bit of muscle mass, that again is going to impact on that. And there are other things which come into play as well. If you're not sleeping particularly well, that can have an direct effect on weight gain. So it tends to be sort of multifactorial.
Yeah, and in a way it's sort of a vicious circle, because when if you're sort of not feeling great, you don't tend to want to go out as much, you tend not to want to exercise, and then it just sort of, I can see how it snowballs.
Absolutely. And any woman who is in this situation has just been through something really significant and really stressful, and I think then thinking, although obviously those things are going to make you feel better, like exercising and eating well. I think women in the early stages and going forward, but need to be really kind to themselves as well, and allow themselves to think, actually, I've just been through all of this and I might be putting a bit of weight on, but I'm going to focus on the one, on the things that I can do to help myself.
Yeah, absolutely. Rosie's asking about vaginal dryness.
Okay, so treatments for vaginal dryness would very much depend on why someone has got estrogen deficiency, what type of cancer treatments that's come from, or whether that's to do with having an estrogen receptor positive breast cancer. So if it's someone who can absolutely take estrogen, and then perhaps they've had their ovaries, perhaps their ovaries have been impacted on by radiation for another type of cancer, then they would absolutely be able to be taking estrogen and hormones to help with that. Yeah. In women who have had an estrogen receptor positive breast cancer, then the first line treatments would be to look at non-hormonal therapies. So you would look at things like vaginal moisturizers. There's a couple of good brands out there. Yes. Riplens. Yes, Riplens. And you can use those 2 or 3 times a week, as much as you need to. It's like a moisturizer anywhere else on the body. And actually, the one thing I would say about that is that's why that symptom really needs to be talked about, and women need to be aware of it, because the earlier you use those, the more effective they're likely to be.
Wow, that's really interesting. I remember when my menopause symptoms kicked in, I found I was so sore there that it was uncomfortable to sit down.
Yeah,
it was excruciating, and I was so upset. And I tried that Yes brand, and it was it really helped.
So that can be good to get used to using those on a regular basis. There are really good lubricants for when you're having sex, and that really needs to be, again, brands like Yes, Silk. There are specific things that are breast cancer now has got some really good information on this.
It has.
Because things like the normal, I won't name a brand because I probably shouldn't do that, but ones that you'd buy off the shelf in a supermarket are in a bright packet.
You can do. I'm not.
Well, things like Durex are probably going to be, they might be great, if you're 21 and you've not got any issues going on, but they're going to be stingy. They're going to be, so it might, it can make it worse actually. But we shouldn't not talk about vaginal estrogens, because they are something that we can consider in most women who've had breast cancer. Now, that doesn't mean that they don't come with any risk at all, but they do come with very, very low risks, because after the first couple of months of using them, very, very little gets absorbed into the bloodstream. So little, in fact, that in women who haven't got any history of breast cancer, we know that using vaginal estrogens on their own doesn't impact your risk of breast cancer. And the problem is in women who've had breast cancer is that you worry that if it elevated it even a tiny bit, that you can't pick up on normal blood tests. Then we need to make patients aware of that, but that doesn't mean that it's not possible to use them. You need to talk about it with a GP or a menopause specialist who knows what they're doing, because they can talk to you about whether that's okay with your particular type of treatment. There are some women who are at certain stages of their treatment that you might want to involve their oncologist to talk about that. Usually as a GP, you absolutely would want to involve their oncologist. But there is an option to use those treatments, and that can be life-changing for some women, because it's not only the vaginal symptoms, but if you've got urinary symptoms, you can have recurrent urine infections and things like that as well.
Yeah, I've heard that's quite common. Somebody's asking about a lady care magnet. Is that safe to use post?
I know. I can't imagine. I mean, I wouldn't like to say. I don't think they really. I don't have any experience of them at all, but I can't see anything which is completely non-hormonal.
I don't even know what it is.
I don't know.
Do you know what? This is really embarrassing. Somebody just knocked on my front door.
Go on.
I think I've got a delivery. Hold that thought. Hang on.
So I think that the magnets might be something that you might be able to enlighten us, whoever's asked the question, might be something that I don't know, do you attach it to your clothing? I'm not sure, but it's not something that I've come across or heard suggested as something that might be helpful. But like I said, you might be able to enlighten us.
Sorry.
Is it exciting?
No, just two boys with I think they were looking for a house party, but they were at the wrong house.
Oh, well,
I wish it was here. Yeah, they could join us. A magnet you wear in your knickers against your pelvic area. Oh, what have I missed? What's been going on this?
It's what the lady magnet.
Oh, I see. My 12-year-old son is now at the door trying to listen into vagina magnets. Can you go, please? Yes. Okay, bye. Anyway.
So no, I'm not familiar with lady magnets.
Okay, fine.
And because I've never heard of them, I would say I've heard of a lot of complementary therapies and things that can help. I wouldn't have thought it would massively help, but then I'm not discouraging someone if they want to try that.
Absolutely.
But equally, I think it's really important that when women are feeling like this, it can be really easy to be sort of preyed upon by companies that are selling something that might be a fix, and actually it probably won't.
Yeah. So how does somebody, because I feel like I'm talking to you now and I'm like, I wish you were my GP, because I feel like I could come to you and like you would listen to me and you'd understand, but it's not across the board. And I bet people watching this will be like, oh, how do we get to somebody like you if our GP doesn't specialise in the menopause? What do we do?
So I think there are things that people can do in the first place. So I know I was talking about breast cancer now. They've got some really good leaflets on. I know you work with some charities as well, don't you? But they've got some really good leaflets on exactly these symptoms and what treatments can help. So if you've been to your GP and you struggle, it would be good to go in with something like that. And actually, GPs have to know an awful lot about a lot of things, and the fact that there's not a lot of involvement with GPs in breast cancer care because it's led by the oncologists or the breast surgeons, actually they really might not be aware of that. They should be aware of menopausal symptoms. So you could take some information with you and suggest things that you'd like to try. Not everywhere. There is a real problem with not being enough NHS menopause clinics in the UK. So I'm lucky. Well, I feel lucky that I work in one in Leeds, so I travel there to do an NHS clinic. So women can be asked to be referred to a specialist menopause clinic, and actually you should be able to be referred outside of area if we have patient choice. So that should be able to happen. The difficulty is, I'm sure you can imagine at the moment, particularly in the clinic in Leeds that I work in with Claire Spencer, who's sort of the lead there, it's absolutely swamped with referrals because women who don't have any underlying issues are still struggling to get HRT. So it, there are long waits and things like that. What I'm really hoping is going to happen, and I know you know about this, myself and Anise Mukherjee and some doctors in Sheffield, I've just seen one of them's joined, are working on trying to improve women's understanding when they have a diagnosis and when they're going to have to take treatments that are going to lower their estrogen, or when they can expect their treatments to massively affect the function of their ovaries. And I think we really need to make sure that information is getting out there so that women understand, have a leaflet given to them which outlines really simply what estrogen deficiency symptoms can be like. You may or may not get them. What treatments can help with that. What you can have, because then it's very clear that that there are options, and you can go to your GP and say, look, I've looked at all of this, this is what I want to do. But in an ideal world, everyone would be able to be referred to a menopause specialist, because this is particularly the group of women who need that input.
Absolutely. And I think just the knowledge that this is absolutely normal of what's happening to you, and you're not on your own, and because you feel, it's a funny old time. If I find it difficult to put into words when you first come out of treatment and all these other side effects are going on.
Absolutely.
And you think you've been through the worst bit after being through surgery and chemo and everything else.
And I can't imagine that, and it must be really so it feels wrong that then we leave people. And I'm not saying that happens, I'm sure there are
and it's
some nurses doing that absolutely, breast care nurses or doctors, doing that absolutely brilliantly. What I think is really important, and that's what's good about menopause clinics, is that you can then work, because you're working in women who have been very filtered down to you rather than as a GP working with everyone, you can have really good links with the oncologists and the breast surgeons and other doctors who might be involved in, you know, hematologists, that type of thing. And you can come up with an individualized plan for that woman. So, and that's the important part, is that it should always be looking at, well, what exactly has happened to this person, and what exactly are their symptoms, and what are the risks and benefits going to be?
Absolutely.
Because for some, not that I would be suggesting anyone did this off their own back, obviously, but for some women, having a treatment holiday is an option to see how they feel. Swapping treatments. I saw that someone had put in the comments on here, and I wasn't aware about this until recently. Some women really find that the brand that they're given makes a massive difference to their symptoms.
Yes.
And a breast
I
surgeon,
didn't realise.
and a breast surgeon who'd had breast cancer herself had told me that. And I think that makes you know, that's really important, but that sort of minutiae of detail and being able to deal with it as a multidisciplinary team is just so important.
Yeah, absolutely. You know what I was thinking about is that if this is random, but go with me on this. If somebody has a horrific car accident, say, and they go in and they see a surgeon, and a surgeon fixes up their leg, they are automatically, and I know this because my mum had an awful car accident, and she had sort of PTSD, like counselling offered to her afterwards, but then also she had physiotherapy to help learn, you know, to move your body properly again. And I feel like it's a bit like this with cancer, that you want that it's almost part of your rehabilitation, almost, to get you back to as much of you as you can afterwards. And I'm so grateful to you and Dr. Anise for trying to help join up these dots, so that we're not left sort of flailing and just wondering how on earth we get back up on our feet again after going through that. And I
think there is a big conversation about HRT at the moment, isn't there? And you know, it's in the media, it's everywhere. And I think that can leave breast cancer patients feeling a bit sidelined. And I know there's also been a lot more information out there about how breast cancer patients might be able to take HRT. And I think that's really difficult as well, because it can leave women feeling, I'm not saying that isn't an option for women at some point, if you know, if absolutely they're feeling dreadful and nothing else, and we've spoken to their oncologist and all of those things. I won't get into that now, but that can leave women feeling that this is absolutely dreadful and nothing's going to make them feel better, and there's no way of getting through this, and not feel very very supported with that. And I think it's all about joining that up and making sure, like you're saying, in that situation where you've had a car accident and you have all those things that come together, and the occupational therapist meets with the physiotherapist, and all of that happens together. Exactly. You know, in women who are going to experience estrogen deficiency symptoms, in an ideal world, a menopause appointment would be part of your
that package, your rehabilitation, right?
That when you are being signed, you know, you've finished having all your chemo and whatever treatments you've had, or you've had your surgery and you're being discharged with your medication, then to have a menopause appointment to say, look, you might not have any symptoms now, but this might happen if you have this. We could help with this. These are what the options are. Unfortunately, you know, that it doesn't exist in the NHS is stretched, isn't it? So that's a pipe dream, really, but it would be really nice if that could happen, especially for the women who are really struggling, or the women that we know are likely to.
Yeah, absolutely. And this is, I think, why we just need to keep having these conversations, you know, until things do change a little bit, and just keep reminding people that there is help out there. And we can't, but by talking about it, it makes us all feel a little bit less alone, which I think is really important. Thank you so much for your time.
Thank you for having me.
I won't take up any more of your time, but I'd love to chat to you again more regularly, maybe, just so that we can, you know, keep going over some of these subjects. And
that'd be lovely, Helen. And it might be nice. And it might be nice to do once we've got those sort of leaflets getting a bit more sort of along the way. That might be good. It might be good to, you know, it'd be great to hear people's opinions on that. And
definitely. Yeah, brilliant. Well, listen, thank you so much, and thanks everybody for joining us and for all your questions. Hope we got round to quite a lot of them. So we'll put on another one again very, very soon, and have a lovely evening.
Lovely to see you, Helen.
All right, take care.
Bye.
Bye everyone.